Everyone, this is a presentation on Oncologic Emergencies, Part 2, Metabolic, presented by Heather Greene, nurse practitioner at the West Cancer Center.
Good morning, everyone. Thank you for joining. We're going to get started on the second part of our presentation on Oncologic Emergencies. Today, we're going to cover 5 of the metabolic oncologic emergencies, and our objectives today will be to identify the risk factors for each of these emergencies, to be able to list the most common signs and symptoms of each emergency, and to recognize key diagnostic tests and interventions associated with each emergency. Our first emergency is disseminated intravascular coagulation, or DIC. DIC is the intravascular activation of the coagulation cascade. This is marked by consumption of coagulation factors and platelets resulting in bleeding. Oftentimes, DIC is triggered by an underlying event, such as cancer in our case, or other factors that we'll discuss later. DIC is oftentimes a more chronic, slower process in the cancer patient that can be seen compared to acutely ill intensive care patients. So how does DIC happen? DIC occurs with the activation of both the extrinsic and intrinsic clotting pathways. The extrinsic pathway is activated with damage to the endothelial lining of the vessel, or in other words, damage to the tissue outside of the blood vessel. The intrinsic pathway is triggered with damage to the subendothelial tissues, or in other words, damage to the inside of the blood vessel. When both of these pathways are activated, they comprise a common pathway, which results in activation of the coagulation cascade and clot formation, as evidenced in this diagram here. As DIC progresses, there is uncontrolled thrombin generation, which results in 2 problems. The first is fibrin depositions that accumulate in the circulatory system. These clots consume platelets and coagulation factors, which lead to diffuse bleeding and ischemic tissue damage, which can result in multi-organ failure and death. Some of the risk factors associated with DIC include patients who are septic or have an underlying infection. Vascular abnormalities can trigger DIC, as damage to the blood vessel can often trigger DIC. Patients who develop severe allergic or immunologic reactions, such as with a snake bite, can also result in DIC. And of course, in our patient population, cancer can be the triggering factor to a patient developing DIC. Those cancers that are most often associated with DIC include cancers of the prostate, lung, breast, and stomach. DIC is also commonly associated with acute promyelocytic leukemia. DIC can sometimes be the presenting abnormality in patients diagnosed with APL. Patients with underlying myeloproliferative and lymphoproliferative disorders are also at higher risk for developing DIC. The signs and symptoms associated with DIC often revolve around the resultant bleeding and thrombocytopenia from DIC. So we may see petechiae or ecchymosis in our patients. We may see other sites of bleeding or pallor. Patients may develop subconjunctival hemorrhage or gingival bleeding. They may have bleeding from the GI tract, including melena, hematochezia, or hematemesis. Patients may have blood in their urine or decreased urine output. From a cardiopulmonary standpoint, patients may become tachycardic or hypotensive as a result of the blood loss. They may have diminished pulses, report hemoptysis, develop shortness of breath or tachypnea. They may be hypoxic or cyanotic. And from a neurological standpoint, they may develop headaches, changes in mental status or level of consciousness, and seizures. The diagnostic tests used to assess a patient in DIC include those factors that are consumed in the DIC process. So in a patient who has DIC, we would see a decrease in those intravascular clotting components. A patient's platelets will be low, fibrinogen will be decreased, thrombin time will be decreased, as will the protein C and S. As DIC results in a depletion of clotting factors, this results in an increased or prolonged prothrombin time in INR, in addition to a prolonged activated partial thromboplastin time, or activated PTT. DIC results in accelerated fibrinolysis. This can be evidenced by an elevated or prolonged D-dimer, an increase in fibrin degradation products, or FDPs, and a decrease in antithrombin 3. You might also notice evidence of cell destruction, such as schistocytes on a peripheral blood smear, an elevated total bilirubin, or an increase in BUN. Treatment of DIC will likely correct itself when treatment of the underlying cause or malignancy is initiated. However, in the meantime, patients may also require platelet transfusions to support the thrombocytopenia. They may require coagulation factor replacement with fresh frozen plasma or cryoprecipitate. And in certain situations, although this remains controversial, patients may require anticoagulants, fibrinolytic agents, and other anticoagulant factor concentrates. Our next metabolic oncologic emergency is the syndrome of inappropriate antidiuretic hormone, or SIADH. SIADH is a paraneoplastic syndrome that results in inappropriate secretion of antidiuretic hormone from the pituitary gland or another ectopic source. Antidiuretic hormone is arginine vasopressin in its active form, and its job is to tell renal tubules to absorb more water and sodium in response to changes in plasma osmolality and plasma volume. In SIADH, however, antidiuretic hormone is released despite normal osmolality and volume. This results in an increase in extracellular free water and results in plasma hypoosmolality and serum hyponatremia, or dilution. This intracellular edema results from the fluid shifting from extracellular into intracellular spaces and can result in complications such as cerebral edema. Risk factors for SIADH include lung cancer, which is the most common cancer associated with SIADH. This may include non-small cell and small cell lung cancers. Certain chemotherapeutic agents also put patients at higher risk for developing SIADH. Those include the zinc alkaloids, such as vincristine and vinblastine, platinum agents such as carboplatinum and cisplatinum, alkylating agents such as Cytoxan, melphalan, or IFEX, in addition to methotrexate. Other medications that our cancer patients may be on, unrelated to their direct malignancy, may also put them at increased risk for SIADH. These include some antidepressants such as SSRIs, or the tricyclic antidepressants, hydrochlorothiazide, and nonsteroidal anti-inflammatories can also put patients at higher risk for developing SIADH. The signs and symptoms associated with SIADH can be vague and may include gastrointestinal symptoms such as abdominal cramping, nausea, vomiting, diarrhea, or anorexia. From a neurological standpoint, and as a result of the cerebral edema, patients can develop personality changes, headaches, or changes in their mental status. They may become disoriented or confused. And patients who develop severe SIADH resulting in severe neurological changes, they may develop seizures and/or coma. Diagnostic tests used to assess a patient for SIADH include a serum osmolality of less than 275 and a serum sodium of less than 130. Urine osmolality will be greater than the serum osmolality, and patients will also have a decrease in the BUN, creatinine, uric acid, and albumin. Treatment of SIADH, again, revolves around the treatment of the underlying cause or malignancy. And treatment for SAIDH depends on the severity or degree of hyponatremia that results. For instance, patients with mild hyponatremia or a sodium of 125 to 143 might only require a fluid restriction of up to 1 liter a day and be instructed to make sure their free water intake does not exceed their urine output. However, in patients who develop a more moderate degree of hyponatremia, such as a sodium of 115 to 124 milliequivalents per liter, in addition to the fluid restriction and restriction of free water intake, they may also be prescribed a medication called demociclin at a dose of 300 to 600 milligrams BID. Demociclin is a bacteriostatic antibiotic that is not commonly used anymore. This is mainly because it causes a usually unwanted side effect of nephrogenic diabetes insipidus. However, this is a welcome side effect in patients with SIADH, as demociclin works to reverse or inhibit renal tubule responsiveness to antidiuretic hormone, which results in nephrogenic diabetes insipidus. This condition is marked by an inability to concentrate urine, reversing hyponatremia. Patients who develop severe hyponatremia or SIADH will have a sodium of less than 110 up to 115 milliequivalents per liter, and oftentimes, in fact almost always, require hospitalization in order to facilitate intravenous 3% hypertonic saline. This is given at a relatively slow rate of 0.5 to 1 milliliter per kilogram of body weight an hour. This solution is given in this fashion in order to prevent too rapid of an increase or correction in the serum sodium, which can result in complications such as pulmonary edema as the fluid shift reverses. Okay, our next metabolic oncologic emergency is tumor lysis syndrome, or TLS. Tumor lysis syndrome results when large amounts of cancer cells are lysed with the initiation of anti-neoplastic therapy. This results in several, sometimes severe, electrolyte abnormalities. These cellular contents that are released into the bloodstream when cancer cells are lysed include DNA, potassium, phosphate, and cytokines. When DNA is released, it's metabolized into adenosine and guanosine, which is then converted to xanthine. When this xanthine is oxidized, it leads to uric acid production, which is normally excreted by the kidneys. However, when this accumulation of cellular contents exceeds the body's natural ability to excrete these contents, tumor lysis syndrome can result. The electrolyte imbalances that can result from tumor lysis syndrome include hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia, and subsequent renal dysfunction. Patients at risk for developing tumor lysis syndrome are those patients who have high-grade lymphomas, such as Burkitt's lymphoma. Both acute and chronic types of leukemia are at risk for tumor lysis syndrome. And those tumors who have large, bulky tumor burden, or tumors that are highly sensitive to chemotherapy, those tumors with rapid doubling times, or patients who have other underlying risk factors such as pre-existing renal disease, patients who are dehydrated, who are hypertensive, have a large spleen, or an elevated LDH are also at risk for developing tumor lysis syndrome. Certain chemotherapy agents put our patients at higher risk for developing tumor lysis syndrome as well. This risk is compounded when you're treating those types of malignancies or tumors that we discussed on the previous slide with agents such as cisplatin, etoposide, or cytarabine. Certain immunotherapy agents and monoclonal antibodies such as Rituxan also put our patients at higher risk for developing tumor lysis syndrome. Patients who are undergoing radiation therapy, particularly to those tumors that are highly sensitive to radiation therapy, may result in tumor lysis syndrome. And hormonal therapy, whether or not this is given in combination with any of the aforementioned agents, can also put our patients at risk for tumor lysis syndrome, particularly those patients who have large, bulky tumors and are highly sensitive to hormonal therapy. The signs and symptoms of tumor lysis syndrome are often associated with the electrolyte imbalances caused by tumor lysis syndrome. For example, patients who develop hyperkalemia may have EKG changes such as tall or peaked T waves or shortened QT intervals. They may report muscle weakness, cramping, or twitching. They may have nausea, be lethargic, or have syncopal episodes. Patients with hyperuricemia also may report nausea or vomiting, diarrhea, flank pain, hematuria. They may be lethargic or report itching, and you may note uric acid crystals in the urine. Patients who have hyperphosphatemia may be oliguric or anuric. They may be hypertensive or edematous. And patients who have hypocalcemia will have muscle tetany, as evidenced by Kavostic or Trousseau signs that we'll discuss on the next slide. They may develop seizures or syncopal episodes. EKG changes can include QTc prolongation. They may be hypotensive, developmental status changes. They may have hallucinations and diarrhea. Two physical examination findings that can be noted in patients who are hypocalcemic as a result of tumor lysis syndrome include Kavostic sign, which is a clinical sign of existing nerve hyperexcitability or tetany. This sign can be elicited when the facial nerve is tapped at the angle of the jaw or the masseter muscle, and the facial muscles on the same side of the face will contract momentarily, typically noted as a twitch of the nose, lips, or facial muscles on that side. Trousseau's sign can be elicited when a blood pressure cuff is placed around the arm and inflated to a pressure that's greater than the patient's systolic blood pressure and held in place for 3 minutes. This will ultimately occlude the brachial artery, and in the absence of the blood flow, the patient's muscle tetany will induce spasming of the muscles of the hand and forearm, as evidenced in the picture here. Treatment of tumor lysis syndrome begins with prevention. Patients who are at risk for tumor lysis syndrome should be aggressively hydrated with oral and intravenous fluids starting at least 24 hours prior to initiation of antineoplastic therapy and up to 72 hours after therapy. Patients may require loop diuretics to avoid the volume overload associated with this IV hydration. Allopurinol can also be used for tumor lysis prophylaxis beginning 24 to 48 hours prior to initiation of treatment. Allopurinol prevents xanthine oxidase, which in turn blocks uric acid conversion and accumulation in the bloodstream. Additionally, treatment of the electrolyte imbalances of tumor lysis syndrome is key. Patients will require frequent electrolyte checks and may need telemetry depending on the level of electrolyte imbalances. For patients who have hyperkalemia, they may be instructed to decrease potassium-rich foods in their diet and may be given medications or removed from medications that increase potassium in their bloodstream. Dialysis may be indicated for these patients if the hyperkalemia is severe or greater than 7 milliequivalents per liter. Other medications that can correct hyperkalemia include furosemide or Lasix, calcium gluconate, sodium bicarb, and insulin. For patients who have hyperphosphatemia, they will be instructed to decrease phosphate-rich foods in their diet. They may be placed on phosphate-binding antacids and might require dialysis again if the level of phosphatemia is extreme or greater than 10 milligrams per deciliter. For patients who develop hyperuricemia, aggressive IV hydration is often indicated, and if they're already on allopurinol, those doses are increased to 600 or 800 milligrams per day. Patients may also be candidates for urate oxidase or rasburicase. This is an IV medication used to lower existing uric acid levels and can also prevent further accumulation of uric acid in the blood. It's given at a dose of 0.2 milligrams per kilogram intravenously for up to 5 days, but should be avoided in patients who have G6PD deficiencies. Again, patients may require dialysis if their uric acid level is severe. And for patients who have hypocalcemia as a result of tumor lysis syndrome, this can be corrected with the administration of calcium gluconate. Okay, our next metabolic oncologic emergency is hypercalcemia of malignancy. This is the most common oncologic emergency, occurring in up to 20% of cancer patients, and is diagnosed when a calcium level is greater than 10 milligrams per deciliter. There are two mechanisms by which hypercalcemia of malignancy can occur. The first is humoral hypercalcemia of malignancy, and this encompasses about 80% of cases of hypercalcemia of malignancy. This is also the most common cause of hypercalcemia of malignancy in patients who do not have bone metastases. And it's important to note that patients can develop hypercalcemia of malignancy without having bone metastases. In humoral hypercalcemia of malignancy, parathyroid hormone-related protein, or PTHrP, is secreted, oftentimes by solid tumors. This results in increased renal and bone resorption of calcium and elevated calcium levels in the blood. The second mechanism of action of hypercalcemia of malignancy is local osteolytic hypercalcemia, or LOH. In this situation, tumor cells in the bones produce cytokines that result in increased calcium reabsorption from the bones. This occurs at the site of a bone lesion or in patients who have bone metastases, where osteoclasts are most active, resulting in breakdown of the bone and a subsequent increase in calcium in the blood. Risk factors for developing hypercalcemia of malignancy include patients who have solid tumors that commonly metastasize to the bone, and those include cancers such as breast, lung, or prostate cancers. Hypercalcemia of malignancy can also be associated with hematologic malignancies, most commonly in myeloma and lymphoma. Signs and symptoms of hypercalcemia of malignancy will depend on the severity or degree of hypercalcemia. For example, patients who have mild hypercalcemia or a calcium level of 10.5 to 11.5 milligrams per deciliter may report vague symptoms such as anorexia, nausea, vomiting, or abdominal cramping. They may be restless, lethargic, or confused. They may report muscle fatigue or weakness. They may report an increase in nighttime urination, excessive thirst, or excessive urination. And on physical exam, you may note that they're orthostatic. Patients who have moderate hypercalcemia or a calcium of 11.5 to 13.5 milligrams per deciliter may have constipation or bloating. Neurologically, they can have mental status changes and psychosis. And from a cardiovascular standpoint, EKG changes associated with hypercalcemia include prolonged PR intervals, widened QRS complexes, shortened QT and ST intervals. They may be hypotensive and may develop cardiac arrhythmias. Patients with severe hypercalcemia of malignancy will have subsequently severe signs and symptoms associated with it. This may include an ileus, seizures. They may end up in a coma. They may be ataxic or develop bone fractures. They may develop acute renal failure, ventricular arrhythmias, and even lead to cardiac arrest. Hypercalcemia of malignancy is diagnosed obviously by their level of calcium on a basic chemistry panel. However, in order to accurately assess the calcium level on a chemistry panel, you need to make sure that you're assessing the patient for any level of hypoalbuminemia. Most of our cancer patients have some degree of malnutrition or nutritional deficiencies that can result in hypoalbuminemia, and a low albumin may result in a falsely low calcium reading on a chemistry panel. Patients with hypercalcemia of malignancy will also have a decreased parathyroid hormone and/or a decreased parathyroid hormone-related protein. On this slide, I have given you an example and a copy of the calculation used to correct calcium levels for hypoalbuminemia. And as you can see here, it's important to make sure that we're assessing albumin levels in patients who may have just even moderate degrees of hypercalcemia. And this patient or calculation noted on the slide, on a chemistry panel, the patient's calcium level was only 10.2. That's a very mild degree of hypercalcemia. However, they were also noted to be severely hypoalbuminemic with an albumin of 2.2. And when you plug these two numbers into this calculation, the resulting calcium level or corrected calcium level is actually 11.6, which is a moderate and almost close to severe level of hypercalcemia and would be treated and approached very differently than those patients with a calcium level of only 10.2. Treatment of hypercalcemia of malignancy, again, revolves around treating the underlying cause or malignancy. Patients will require aggressive IV hydration with normal saline, with or without the use of a loop diuretic to avoid volume overload. Patients will require bisphosphonate therapy, most commonly in the form of zoledronic acid or Zometa at a dose of 4 milligrams IV over 15 minutes. Another alternative is denosumab, or better known as Xgeva. This medication is a monoclonal antibody used to inhibit osteoclast activity. It's given subcutaneously at a dose of 120 milligrams. Additionally, some patients can be prescribed calcitonin with or without the use of corticosteroids, and less commonly, gallium nitrate can be used. However, this medication is oftentimes avoided due to its significant nephrotoxicity. Moving on to our next metabolic oncologic emergency, which is the Systemic Inflammatory Response Syndrome, or SIRS, encompassing sepsis and septic shock. SIRS criteria were developed in order to aid in recognition of a patient's progression from infection to sepsis. 2 or more of these SIRS criteria are needed to diagnose a patient with sepsis. SIRS criteria include patients who have a temperature of greater than 38 degrees Celsius or 100.4 degrees Fahrenheit, or patients who have a low temperature of less than 36 degrees Celsius or 96.8 degrees Fahrenheit. The next SIRS criteria is a heart rate of greater than 90 beats per minute, a respiratory rate of greater than 20 breaths per minute, and a white count of greater than 12,000. It's extremely important to be able to recognize a patient's progression into sepsis early in order to improve patient outcomes, further stressing the importance of being able to identify patients who qualify for SIRS criteria. So what is sepsis? Sepsis is a systemic response to an infection, and whether that infection is bacterial, viral, or fungal, it doesn't matter. The systemic response to infection is the same. Sepsis causes several things to occur in the body in response to the underlying infection. This includes vasodilatation and an increase in vascular permeability. Patients will develop a decrease in arterial and venous tone, and on some occasions clots may form. When sepsis is left unchecked, these changes can result in organ damage, hypotension, and hypoperfusion, resulting in a more severe degree of sepsis. As this sepsis progresses, vasopressor support may be indicated, indicating that the patient is in septic shock, which again, if left unchecked, may result in multiple organ failure and even death. Risk factors for sepsis include myelosuppressive chemotherapy that may result in neutropenia, and commonly seen in our patients, febrile neutropenia. The placement or existence of vascular lines, catheters, or drains may also put a patient at risk for infection, further increasing their risk for developing sepsis. Respiratory and urinary tract infections can also place a patient at higher risk for developing sepsis, as can mucositis. Patients who are elderly or greater than 65 years of age, patients who have a poor nutritional status or who are already hospitalized also have a higher risk of developing sepsis. I've outlined for you here a table encompassing the signs and symptoms and the difference between sepsis and septic shock. Patients who are septic may develop mental status changes which can progress to obtundation and even coma if they develop septic shock. Patients who have sepsis may develop tachycardia or hypotension progressing to cardiac arrhythmias if septic shock develops. Respiratory changes associated with sepsis include tachypnea or hypoxia, which can progress to all-out acute respiratory distress syndrome if a patient develops septic shock. Renal changes include a decrease in urine output that again can progress to complete anuria or acute renal failure in septic shock. And GI changes of sepsis may include vague nausea and vomiting, which can progress to encompass jaundice and decreased GI motility if septic shock develops. Skin changes associated with septic shock may be noted in the form of skin mottling or hypoperfusion. The diagnostic tests used to evaluate a patient who is septic or in septic shock revolve around identifying the source of the infection and assessing the level of organ damage and/or involvement. Patients will require cultures from multiple sources, including the blood, urine, sputum, and any open or visible wounds. Stool studies can be used to identify any underlying infection in the stool. A chest X-ray and/or CT scans can be used depending on the level of clinical suspicion for the source of the underlying infection. Patients will require a CBC and complete metabolic panel in order to assess the level of organ damage as a result of the sepsis or septic shock. And as we discussed previously, sepsis is a risk factor for DIC, therefore a coagulation panel is indicated. Patients need a lactic acid level and arterial blood gases to also assess the level of sepsis and/or development of septic shock. Patients who are septic will develop an elevated white blood cell count. They may have thrombocytopenia and hyperglycemia. The coagulation panel may be skewed as evidenced by a prolonged PT and/or PTT. They may have a decrease in fibrinogen, but will have an increase of lactic acid. Patients who go on to progress to septic shock will have evidence of liver and renal failure and/or damage. They may become anemic and may become hypoglycemic. Treatment of sepsis and/or septic shock is initiated with aggressive IV fluid support, usually with normal saline. The initiation of broad-spectrum antibiotics is indicated within 45 minutes of recognition of SIRS criteria and/or sepsis. The antibiotic should be administered early and quickly, but only after cultures are obtained in order to avoid missing and recognizing the underlying pathogen. If patients develop septic shock, they may require vasopressor support to maintain a mean arterial pressure of 65 millimeters of mercury. The most common vasopressor used is norepinephrine or Levophed, which would require an arterial catheter to be able to monitor the mean arterial pressure. Additional supportive care measures include oxygen therapy, insulin, blood product support. Normally, patients require PRBCs if the hemoglobin is less than 7, platelet transfusions if the platelet count drops to less than 10,000, with a goal to keep the platelet count at or equal to 50,000 if the patient has active bleeding. They may require fresh frozen plasma support if DIC is accompanied in the sepsis process. If patients develop renal damage or failure, they may require renal replacement therapy or intermittent hemodialysis, and these patients would also require DVT prophylaxis. In summary, it's important as nurses for us to be able to recognize the early signs and symptoms of these metabolic oncologic emergencies in order to intervene early, as this results in better patient outcomes. It's also important to remember that treatment of these metabolic oncologic emergencies is also dependent on treating the underlying cause of these emergencies, oftentimes resulting in initiation and treatment of their underlying malignancy. Thank you.